Hi and welcome back to another video for physiology questions. Let's start with the first question. A pressure measuring probe is inserted into a segment of the digestive tract located past the ileocecal valve in a healthy adult. The probe detects a consistently high baseline pressure that remains stable without significant fluctuations. However, when the area immediately upstream becomes stretched or filled, the recorded pressure briefly drops to zero. No defecation occurs during this pressure drop. Based on these findings, where is the probe most likely located? In this question, we should recognize the clues which are given. There are three clues in this question. Number one, high resting pressure. This indicates a location with constant tone rather than fluctuating peristaltic activity. Number two, the fact that the pressure drops to zero with upstream distension. This suggests a reflexive relaxation in response to upstream distension. And number three, no defecation occurs. This point rules out voluntary processes or active propulsion of content. The options which are given here are A, sigmoid colon, B, cecum, C, descending colon, D, external anal sphincter, E, internal anal sphincter. The correct option here would be E. The internal anal sphincter is under involuntary control by the autonomic nervous system, specifically the splanchnic nerves. It maintains high resting tone and relaxes transiently in response to rectal distension. This response is known as rectoanal inhibitory reflex. Let's break down the rectoanal inhibitory reflex in more detail. When the rectum stretches, the stretch receptors are activated. These receptors send afferent signals via the pelvic nerves to the sacral segments of the spinal cord. The sacral segments, which is the S2 to S4, they process the afferent signals and prepare to initiate a response through the autonomic nervous system. The processed signals are sent back through efferent fibers of the splanchnic nerves, instructing the internal anal sphincter to relax temporarily. As the internal anal sphincter relaxes, rectal contents are allowed to move closer to the anal canal, facilitating the potential for defecation if desired. Let's have a look at why the other options are incorrect. Option A, the sigmoid colon would display fluctuating pressures due to peristalsis. It does not maintain a constant high resting tone. Option B, the cecum, which is part of the large intestine, may hold contents temporarily but doesn't maintain high resting tone. It's not a sphincter, so the pressure would fluctuate with peristalsis. Option C. Like the sigmoid colon, the descending colon also undergoes peristalsis, creating fluctuating pressures. And option D. The external anal sphincter is under voluntary control by the somatic nervous system. While it does maintain a resting tone, it only relaxes with voluntary effort during defecation. A 24-year-old man presents to his physician with persistent leg discomfort and feeling of coldness in his feet. He denies any past medical history and his vital signs are stable. On examination, arterial pulses are diminished and delayed in both lower limbs with a noticeable difference in blood pressure readings between the arms and legs. ECG shows evidence of left ventricular hypertrophy. Chest X-ray reveals a prominent aortic arch and enlarged aortic knob. Which of the following is the most likely underlying cause of this patient's symptoms? The key points to focus in this question is number 1, pulse discrepancy and blood pressure difference. This suggests obstruction somewhere along the aorta. Number 2, the left ventricular hypertrophy indicates the heart is working hard to push blood through a narrowed segment. And number 3, the chest X-ray findings of prominent aortic knob and dilated aortic arch suggest structural or post-stenotic changes. The options provided here are A, mitral regurgitation, B, aortic stenosis, C, aortic coarctation, D, peripheral artery disease, E, deep vein thrombosis. The correct option here would be C. Aortic coarctation is a congenital narrowing of the aorta, usually distal to the origin of the left subclavian artery. This narrowing increases afterload, leading to left ventricular hypertrophy as the heart works harder to pump blood past the constriction. Additionally, blood pressure is higher in the upper extremities compared to the lower extremities due to the obstruction. Pulses are weakened or delayed in the lower extremities. A prominent aortic knob and dilated aortic arch on X-ray can result from post-stenotic dilation or collateral vessel formation. Let's have a look at the other options. Option A, mitral regurgitation, causes backflow of blood into the left atrium, which leads to volume overload and left ventricular hypertrophy. It does not cause pulse delay or significant blood pressure differences between extremities, and the symptoms usually include dyspnea and fatigue. Option B, aortic stenosis. It causes narrowing of the aortic valve, which increases resistance, leading to left ventricular hypertrophy. The symptoms, they include chest pain, syncope, and exertional dyspnea, and not leg cramps or cold feet. Option D, peripheral artery disease, is a condition characterized by atherosclerotic narrowing or blockage of peripheral arteries, most commonly affecting the lower extremities. It typically affects older adults with risk factors like smoking, diabetes, or hypertension, and the symptoms include intermittent claudication, coldness and numbness in their legs, weak pulses, shiny skin, leg weakness, and slow healing sores. And option E, deep vein thrombosis, is blood clot formation in deep veins, typically presenting with unilateral leg swelling and pain. The symptoms include redness, warmth, and tenderness, but no blood pressure differences. And it does not cause left ventricular hypertrophy on the ECG.